Over the last couple of weeks, we've discussed the history of modern medicine in America. Today, it's time to dissect where we've ended up and what the future may bring. It's quite obvious that we've made astronomical advancements in so many aspects of science and medicine. Our growing knowledge of disease and the human body have helped contribute to life-saving therapies and a decline in deaths from conditions like heart attack and stroke. However, Dr. Jeremy Green is quick to point out that we haven't yet reached the pinnacle of healthcare. In fact, we may even be regressing in some ways.
We are in a moment in the United States in which some of the major public health improvements of the 20th century are showing some signs of backsliding in terms of where things are with overall longevity. And this is also not even to speak of the problem of disparities, right? Racial disparities in maternal and child health. We know that the disparity has actually widened between the 19th and the 21st centuries of the likelihood of complications from childbirth.
Green is a physician, professor, and director of the Institute of the History of Medicine at Johns Hopkins School of Medicine. He notes that not everyone is doing worse. Many people benefit from our current medical system. However, the health gap between Black and white women when it comes to maternal morbidity is wider today than it was in the 19th century. Despite our advancements, a 2023 paper in the journal Healthcare estimates that pregnancy-related deaths of African Americans are more than 4 times higher than white women.
And part of that is because the benefits of modern medicine have not been spread equally among all people by any means in this country. And part of it is because the fundamental social determinants of health and disease have not been distributed evenly across American society either. And so this is oftentimes something we forget about when we simply think of the aggregate improvement in public health measures, is that can coexist with an aggregate worsening of racialized health disparities at the same time.
Racial disparity is just one of the many issues present in today's medical system. Another hurdle that's the center of many patients' frustration is how fragmented our system has become. The American Association of Medical Colleges recognizes more than 160 specialties and subspecialties in the U.S. While many believe specialties are necessary for quality care, Dr. Helene Langevin says the patient's larger health issue can easily be overlooked when physicians focus on just one area of the problem.
A lot of medicine is very specialized, right? People will go to a specialist for their heart or for their kidneys or, for their knee, and a lot of that is kind of fragmented. And even, for example, when you have a general internal, like I used to practice internal medicine, but even with internal medicine, you really think about the organs and the systems of the body pretty one at a time.
Langevin is the director of the National Center for Complementary and Integrative Health at the National Institutes of Health. The fragmented state of healthcare isn't anything new. In fact, Green says it goes back hundreds of years. Even general internal medicine, which handles a broad range of conditions, is a specialty. Actually, it's one that developed after many other disciplines.
So in a way, if you look at that moment, right, in the middle of the 20th century, general internists started saying, hey, we need a new specialty that's called general internal medicine so that we can capture this larger thing. Primary care is actually founded as a specialty even later than that, even though we think of it as this older thing that's being lost. So even this concept of what is the holistic element and how we need these holistic spaces so that we don't become hyper-fragmented in medicine, these are also themselves specialties, and they're more recent specialties.
Though our world has a history of breaking the body down into tiny sections, there's a major benefit to combining this specialized style with a broader view of the patient. This type of approach is called integrative medicine. It's a method of care that takes a person's whole body and lifestyle into account.
What integrative health or integrative medicine tries to do is it really tries to look at connections across all of these systems, as well as across the different, what we call domains of the body. So biological, behavioral, social, environmental. So it's really looking for connections across all of this.
Integrative medicine also utilizes both standard therapies like drugs and surgery, as well as complementary ones like yoga and acupuncture. Langevin says it can be especially helpful for chronic conditions.
A lot of times when people have chronic diseases, they don't have just one. And a lot of times these problems are related. So it's very interesting when somebody is, for example, under a lot of stress and they're not perhaps eating the best diet that they could, and maybe they don't get a whole lot of exercise,
which could lead to weight gain and increased blood pressure. It may start to affect the kidneys and cause inflammation, which can easily damage other organs in the body. In this situation, it's easy for a specialist to only look at the one issue and fix the symptoms there. But that's not ultimately helping the patient's overall health.
These are not separate problems. They're all related to the lifestyle and the behaviors. So it really helps to have an approach that really looks at these behaviors that can be improved as long as they're given the right support for good diet, support for like physical therapy, for example. If somebody has a problem with their knee and they have problems exercising because their knee hurt, well, they need help with that. Or problems with stress, they can't sleep. So they're tired and they're exhausted and, they need help with that too, right? So there's a lot of things that can contribute to health of the whole person that needs to be coordinated.
Langevin discovered integrative medicine when she was practicing as an internal physician. She went on to research acupuncture and ended up as the director of the Osher Center for Integrative Medicine at Harvard Medical School. While Langevin was in that position, she worked to blend some of these practices into students' medical education. She says that it's also becoming more mainstream for physicians to think about complementary therapies instead of going straight to painkillers when patients have chronic pain.
The actual clinical guidelines that are issued by many different organizations are saying that your first, especially for somebody with chronic pain, your first line of treatment includes things like acupuncture, things like manual therapies, exercises, those kinds of things. That's what you're supposed to do, And so I think more and more there's the recognition that these different options are valuable.
However, no matter how valuable these methods may be, it takes time to fully integrate them into the system. There are a few hurdles before reaching the end goal, like awareness, education, and acceptance by the medical field.
And this is not unique to integrative health. This is everywhere. This is why at NCCIH, we do some of that type of research, which is called implementation research, where we're looking for what are the barriers to implementing a specific type of treatment that we know works. So why is it that in certain healthcare settings, why is it that it's not being utilized? This really came to a crux during the opioid crisis, right? Where we found out that a lot of people were being prescribed opioids for their chronic pain. They shouldn't. So why is it that people were still being prescribed opioids when there are some instances where opioids obviously are appropriate, but there's a lot of times when they are not. And so more and more, we're trying to understand exactly what would it take, to facilitate the implementation of these non-pharmacological therapies. And we're starting to understand better.
One barrier Langevin's noticed is the time a physician is willing to give. They're under a lot of stress, fitting back-to-back patients into small appointment windows. Many may not be willing to take the extra minute to explain complementary options.
It takes a lot less time to write a prescription than it takes to make a referral to, say, an acupuncturist or to do counseling, for example, like if somebody needs to improve their diet or they need to get a little bit some more exercise. If you don't have the time to do that, it becomes very difficult.
The answer to this problem? The doctor can't do everything. Instead, Langevin advises to build an in-house care team that includes a health coach, a nutritionist, a therapist, whoever is needed to look at the patient as a whole human, instead of pieces of symptomatic flesh. And as integrative medicine becomes more embedded into our healthcare system, the next step is to look toward how it fits into medical education.
It would be ideal if this was taught in medical school right from the start. I mean, there are a few, medical schools that are starting to integrate that into the curriculum from the start. And I would say it's not the majority. There's a lot to learn in medical school, right? So if you're going to try to introduce a new part of a curriculum, you have to take something out. And it's very difficult to do.
However, the Academic Consortium for Integrative Medicine and Health is leading the charge for change. It provides members with the best practices in care delivery, research, and education for integrative medicine. Today, 75 U.S. medical schools are members, including many of the nation's top universities. You can find more information about Dr. Hélène Langevin, Dr. Jeremy Green, and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield.